Right. Hello. I'm Richard Wood. I'm going to give a presentation today on our project IPACS, Improving Patient Flow Between Acute, Community and Social Care. So this project is within the Southwest Better Care Partnership, led by Professor Jonathan Stern, who's the programme lead. And within our programme, we have 5 projects. So we have 4 modelling or analytical pieces of work, of which the one I'll be talking to you today is one of, and a 5th project, which is about improving a linked data set, which is essentially the enabler to the other 4 projects within the programme. So this whole programme started back in June, and it runs for 3 years, finishing in May 2023. So it'll be project number 3 on that list there, the IPACS one to present today. And as well, I'll just say a little bit at the end around how we're working to improve our linked data set. That is a crucial enabler to the IPACS project as well as the others. So really the key problem that that kind of underpins this project is delayed transfers of care, or detox. So these occur when patients are ready for discharge from the acute hospital setting and are not able to be promptly discharged for could be many reasons. Principally, it's an issue of downstream capacity, available capacity. In either the community or social care setting when we're talking about complex discharges. So that's typically older patients who have had a non-elective admission to an acute hospital, who then it is not always easiest to discharge promptly into the remainder of their pathway. So there's been little research and analysis on this matter. In this problem, really, of one of the studies, it's found that there's been approximately 500,000 acute bed days lost per year, and that's just down to social care capacity in terms of these detox, and that costs millions, hundreds of millions of pounds there. So this isn't just a problem because, of course, it's expensive to keep patients in hospital when they don't need to be there. This also causes operational issues, as patients occupying a bed in an acute setting mean that it is more difficult for others who need to also occupy a bed to be able to do so. So this then has consequent effects upstream, so further up the pathway, in terms of causing surgery cancellations for elective patients, and onwardly even into accident and emergency. If patients cannot be admitted to the acute bed base, then there's overcrowding there, which then consequently means that it's difficult for ambulances to drop patients off at A&E units. Also, detox are bad, really, because if you're a patient, you don't want to be in a hospital any longer than you need to be. So it can result in things like pressure sores, as well as reduction in not just physical but also mental independence, and that can even result then in rather than being discharged home, actually requiring a care home placement. So again, maybe not what the patient would want. They would rather retain independence, but also very costly from the service provision perspective. So the current state of the art then, in practice, we're using very primitive methods really to address these kind of problems and questions, really, in terms of the modelling sense. These models are often based on averages. They do not appreciate the real important variability in arrival rates, in length of stay within hospitals, and in the discharge delays. These approaches are well known to considerably underestimate capacity requirements when applied to a pathway and patient flow. In terms of the research that has been done, there's been pretty limited research in this area. This might be down to a lack of research-ready linked data across health and care. And from what we could find, there's very few, less than a handful, potentially relevant articles that could be that are addressing this issue. So this means it's a really significant opportunity for applied research. The approach we're looking to take in this project is stochastic simulation. So we're basically simulating patient flow along this pathway from acute discharge readiness through community to social care. We're using queuing theoretic methods to develop what will be a dynamical model. And then we'll use this as part of a what-if hypothetical scenario analyses to determine what will be the optimal pathway configuration in terms of where to allocate capacity and funding to those different settings of care, with the hope that this will improve operational performance as well, crucially, as patient outcomes. So where we've done such similar modelling in our system before has been around looking at, for instance, stroke pathways, where here we've included 2 options for a hyper-acute stroke unit along a centralised pathway, options that we're looking at the moment within our system. So this enables us to model the flow along those pathways and understand where we need the capacity, where bottlenecks may be likely to form, and thus the mitigations for those. One of the key insights that we envisage outputting from this work is to understand the optimal budget allocations between health and care. So we want to really test the hypothesis that if we invest more in social care, i.e. the downstream care, then we can bring about a net system saving, because this will consequently reduce the detox, i.e. the activity and the cost in the more expensive upstream setting, in the hospital setting. So this is one of the things we're really looking to test in this project. The progress to date has been surveying the literature, identifying others working in this space around the UK. We've been setting up locally relationships with key people across the whole pathway through acute, community and social care. And we'll be reviewing various sources of data existing across the system. In recent weeks, we've been working very closely with analysts within the system to understand their model, their current approaches, their current methods, and basically to use those as a foundation to sequentially improve and increment in stepping up the sophistication of the model, rather than attempting to go in all at once with a very different, sophisticated approach, which may not be well received. So the loop, all of the better care programs projects have a loop which talks to the way that the work will be developed and then scaled up. And in this project, we absolutely envisage that there will be a lot of scaling up of the model, the insights through this work. First of all, through to our regional partners in this project, and then more widely in the NHS. So as mentioned at the beginning, there's a project within our Better Care partnership to develop, improve our system-wide data sets that is of crucial importance to not just this project, but others within the partnership. At the time of that we were brought into the Better Care partnership, our linked data set essentially looked like this: 2 tables, an activity and attributes table, comprising activity data from primary, secondary, mental health and community services for all our 1 million residents in our population. The system-wide data set really is comprised of 2 tables, attributes and activity. The attributes table is a table containing 1 million odd rows for each member of the population, going across about 200 columns containing long-term conditions, socioeconomic, demographic, and so on data fields. The activity table is over 50 million rows containing all sorts of different patient-related activity. So this is discrete patient contacts such as GP appointments, outpatient consultations, A&E attendances, and so on. In recent months, we've brought in wider determinants from our local authorities into the attributes table. So this is information such as educational attainment, access to green space, that kind of thing. Also, we've been bringing in social care data across our 3 local authorities, and that has been brought into activity data table, as well as a new referrals table that we're creating. There's many future plans, one of which is to enhance that referrals table with other referrals information, not just to from social care, but also primary care, secondary care, and so on. We also plan to add in additional patient-related attribute information into the attributes table, so not just from primary care and wider determinants data, but also from secondary care, mental health, community, and social care. Also, we're looking to replace the flows of data that we currently get from NHS Digital with local flows that we have more control over. And this will involve setting up a single data sharing agreement for those flows that do currently stem from NHS Digital. We're also going to be expanding the coverage of the activity table, bringing in other data sets, 111 data, 909 data, IAP data, to expand the range of information that we cover in the data set. And finally, we're going to be bringing in additional dimensions such as diagnostics data, as well, crucially, as outcomes, which is really important if we're to move towards value-based commissioning and delivery of health services. It's crucial that we understand not just the cost of all of our activity, but also the improvements in outcome that each such activity brings about. And just finally then to introduce other members of the IPACS project team, being Dr. Paul Forte, Dr. Alison Harper at Exeter University, as well Professor Martin Pitt at Exeter University, and Professor Christos Vasilakis at University of Bath.